get started, or should we just get one more minute? Okay. Okay, so we're going to start in a minute. If you could be seated. Thank you very much. Okay. So we're in our second research roundtable. I would like to regard this as a continuing discussion of the excellent, innovation panel yesterday that Kenny moderated. I hope that we still remember that something discussed in that panel. One great speaker is Pete Silano, right? So from MedStar. So he actually talked about moving all the doctors in his system to online, specifically to ZocDoc, so that patients can book doctors immediately online. And he said that that's a huge impact. And his wife tried it, and she likes it. She recommends everyone try it. Right? Next time you want to make an appointment, go online. The reason is very simple. The reason is that if you want to call your doctor, right, and make an appointment, you will wait for one week, right, sometimes. And if you go online, you could get an appointment immediately or the next day. The reason, again, is very simple. That's although doctors are very, very busy, they also have a lot of cancellation and no-show of patients. So there are slots available, but they are not available to you unless you go online and check that. So we do see a change of paradigm of healthcare delivery. And with more and more doctor-patient interactions moving to the online setting. So our panel today is really going to talk a lot about one key aspect in this paradigm shift. That is, once you go online, you will see multiple doctors available. Then which doctor you should choose, right? So basically, it's about the doctor's online reputation and computation. So with that, let me introduce our great panelists. We actually is truly international. So we have Heiko from Germany, and he flew actually 8 hours, 30 minutes and 5 seconds. I would be very precise with you, but that's not accurate enough, I guess. Then we have Srikanth, right, from University of Buffalo, and we have Xu from University of Connecticut, and finally we have Jia, right, flying over 13 hours, from Shanghai here. So welcome. So without further ado, let me move over to Heiko, talking to his research on the online ratings for doctors.
All right. Thank you, Gordon. Morning, ladies and gentlemen. Pleasure to be here. It's actually, if I'm not mistaken, the 6th time I'm here. So I'm a long-term supporter of the White Workshop, and thank you so much for having me today. I would like to present a little piece, like a really, really little piece of research here. We already heard yesterday a bit about online ratings of physicians, and we saw a lot of quantitative work. So how are these ratings being perceived? What do people rate, etc.? So we were taking an approach to the other side. What actually motivates people to rate a physician online? What are the influential factors of that? As said, more like exploratory work here, so we actually did an interview-based study. We all know online ratings of physicians, of general practitioners, is gaining in importance. The US is probably a bit ahead of Germany here, but we are catching up slowly but steadily. To be exact. The market is not yet as developed as like the rating systems in eBay or on Amazon, which play a vital role. Doctor ratings are different, especially as it is an intangible good. So how do we actually rate a physician? So what motivates you to do it, and what are the influential factors behind it? We got lucky, well, actually one of my students got lucky, so he got access to, got lucky was bad English now, right? Okay, forget about it. one of my students had the great pleasure, that's what I actually meant, to work together with 8 general practitioners and their patients. So they actually granted him an office in their clinic, and he sat there, and before the patient actually entered the physician's office for the consultation, he passed by my student, and he had like a semi-structured questionnaire, 11 questions, and asked the patients some questions about his expectations, how good and bad is feeling, etc., etc., etc. And after the treatment, the patient passed through that room again and had another 11 questions. So each of these 2 short interviews took between 5 and 10 minutes, and we were able to collect 103 interviews during our 6 weeks period. Some limitations, obviously only 8 physicians, and for some very weird reason, we haven't found it out, we have a massive skew towards younger people. So one would expect old people to go to the physician. In our sample, we had a massive skew towards people under 50 years of age. Couldn't figure out why. Maybe young people were sick in that time. Also, obviously, all the measures are self-reported, and there may be a significant social desire an SDR in there. Would you rate the physician thereafter if I'm the interviewer and I'm interview Kenyon as a patient? The likelihood that Kenyon answers, "Oh yes, of course I do," is much higher than if there would be no interview. Unfortunately, we were not able to check whether the the patients actually posted that review thereafter, and if we would have been able, there also might be a Hawthorne effect in there. However, a very, very simple model we had. So we wanted to measure the experience. How did the patient feel for the treatment there? Were the people nice? Was what the correct term bedside manners I learned yesterday? So did the physician have good bedside manners? Was the waiting time acceptable, etc.? Then we thought about the diagnosis. So how did the patient perceive the diagnosis, as good or bad? Does the patient have any knowledge about illnesses, his illness, the specific illness? And then, as a dependent variable, what type of review would he or she perform for the physician? Findings, naturally not really counterintuitive. If the patient had a good experience, short waiting time, friendly staff, nice offices, the rating was overall good in the end. Having said that, we wonder why so many physicians have so ugly offices. If you actually know that the office space, the waiting area, has a big impact on the patient's perception, why don't you invest more in giving them a good time there? Another question to be solved later on. We didn't find any support for the negative impact of the negatively perceived diagnosis. However, we only had 2% of people who actually got a negatively perceived diagnosis. So very thin on data there. If the patient perceived the treatment as good, the physician was rated good, and we did not find any significant or systematic influence of the knowledge about the diseases. Side note, it was very interesting. People only had knowledge about illnesses when they were actually ill or perceived themselves as being ill. If they perceived themselves not as being ill, they didn't want to get in touch with illnesses. I don't care for illness if I'm not actually ill. So this is something we need to take further on. And I'm almost over my 5 minutes. Actually, I am over my 5 minutes. So thank you very much.
Very good morning. So we've been pointing fingers at the physicians for quite a while. So I think it's only fair that we ask ourselves or ask the patients, what have you been doing? So let's turn it around and see what patients have been doing in online health communities, and are they really spreading correct information? So that's what I'm interested in. And I'm Srikanth, I'm from Buffalo, and one of my co-authors and my professor, Professor Raj Sharman, is here. So let me cut to the chase. So what we are actually interested in here is that we have more than 60% of adults in the US look for health information online, which is probably not surprising for the audience here. And the good thing to hear is that, for me at least, that 40% of them have used social media for the same. But so the impact is that the patients get to talk to other patients who are similar to them and get some experiential evaluations. So, and the flip side to that is the patients are often anonymous, and they really may not give you the right response to whatever question you might have, because of obvious reasons that patients may not know enough, have enough clinical knowledge, and the patient might be different from the person who is actually seeking the information. And what has worked for one patient may not work for the other. So that is what we are actually concerned about here. So is there any misinformation that is spreading in these networks, and what is its impact? So the idea behind that is that what can we do? Say if we find that there is something going wrong, then we can identify some pointers, like some cues, which can be then used to provide some alerts to the patients on the probability of misinformation, and try to incorporate that in the design of such websites, hopefully to contain the misinformation. So then the question comes, like, how do you know that this piece of information is correct or not? Well, we obviously had to go back to the physicians who are the experts in the field. So we made use of a couple of physicians who actually evaluated these posts and threads based on certain criteria. So let me just quickly go through what the data is all about. It's related to diabetes discussions in a particular forum. And we had patient-provided data like age, gender, when they were diagnosed, and what kind of diabetes they have. So, and also some internet characteristics like how often they use the system itself, and how many likes they get, likes in the sense how many users, how many other patients have rated them as good, and also how experienced are they with the portal itself. So, and then we had the physicians, we actually developed a specific application which enables these physicians to actually go and evaluate the responses based on whether it was relevant and accurate for that given question that any user might ask, and also certain characteristics of the question as well, whether it was complete and how complex the question itself was. So, so broadly, we derive. What derived our was the basis of the selection of the variables was that it was based on some cognitive and behavioral studies, and some communication studies related to the credibility of information, which say that users generally look for cues online when they don't have much information about assessing or enough information to assess what a particular user is whether really an expert in that particular area. Then they usually look for certain cues like how many likes they have and how experienced they are with the topic itself. So in this case, how experienced they are with the disease, and how similar they are to themselves, like do they have similar disease characteristics and so on. So, and we also looked at some contextual variables, like since this is a diabetes forum, we looked at what proportion of the users that they are interacting with have type 1 versus type 2, and were there any emotional content involved in that. So just to quickly give you a summary of our findings, since I'm running out of time, what we actually found out was that the general cues that patients look for when they go to such websites, like you might imagine yourself as a user, you will probably look for other users who have been participating for a while, who have a lot of likes. Then you think that, okay, they might be good. But it turns out that it's not the case in these online health communities from the perspective of the physicians, because clinically they may not be right, but they might be providing certain responses which the users think might be useful for them. So the indicators that might have been used previously for judging the expertise or credibility of a piece of information do not seem to hold good. So Since I'm running out of time, I'll just end with this. Thanks a lot.
Okay, good morning. I'm Xu Han from University of Connecticut. Today I'm going to talk about how to optimize this CMS nursing home rating system. This is the system. It rates a nursing home in 3 measures: health inspection, staffing, and quality measures. Something interesting here is only the health inspection is inspected by CMS. Okay? The other 2 are self-reported by nursing homes. So the overall rating is given as a combination of the 3, and the nursing homes get 1 additional star if any of the self-reported measure is 5 star. So this mechanism gives nursing homes the incentive to report better in order to look better, right? Then that will lead to rating inflation. So evidence have been shown that this rating inflation does exist in the current system. So in this research, we seek methods to improve this system. And here are the research questions we ask. First, suppose CMS only select 1 measure to do inspection. Which one shall be selected? And also, if some audit policy is necessary for the self-reported measures, and how to set the parameters for auditing. Okay. To understand the idea, let's first take a look at this example. Suppose we teach a class, a small class with 5 students, and we want to give an exam which consists of 2 questions, A and B. So this table here shows the true grade that student can get for this exam. Okay. 0 means cannot do it correct, and 1 means correct. Okay. And what we also have is the historical reading, okay, the historical data of how the students do in this exam. So we have each pattern with the corresponding possibility to observe it. Okay. So now suppose you get lazy, and you only want to grade 1 of this problem. My question is, which one are you going to select, A or B? So who wants to grade A? Please, hands up, please. Okay. I feel okay. Who wants to grade B? Okay. So, so apparently most of us don't want to grade anything. So, all right. So let's take a look at this question. Okay. So from the table, the first table, we see that 4 students can cheat on question A. Only 2 can cheat on question B, right? So I was thinking if we grade question A, then basically we minimize the population of students who can cheat, right? But this is good until you want to catch the cheaters, because you will find that the first 4 students, they just show the same pattern. And there's no way that you can find a cheater in this. But when you grade B, things can be different. Okay, now the cheaters will cheat on A, and this is the result you will observe. And because 1, 0 from the historical data is some rare pattern, and you can catch the cheaters very easily. So coming back to the nursing home inspection measure selection problem, 2 objectives can be used. First, minimize the population of nursing home who can cheat, and then minimize the difficulty to catch the cheaters. Okay, so to solve this problem, this is what we developed, a graph-based framework. And I don't think I have time to go into the details here, but the major takeaway here is when we minimize the population of nursing homes who can inflate, CMS should inspect on the staffing measure. But when we minimize the difficulty to catch the inflators, then CMS should focus on the health inspection measure. But that also means that an effective audit is necessary. So in the next, let's take a look at how we design this audit procedure. There are 3 parameters we want to set here. P1, P2, that's the audit probabilities for nursing homes whose rating increased 1 star or 2 star after self-reporting. Okay? And also the caught inflators will be punished by rate R. here we assume that there are honest and cheaters. Okay, honest nursing homes will report the truth, whatever audit policy is used. But the inflators, they will calculate the expected profit when it outweighs the expected cost. Then they will inflate. And for CMS, they has a net budget B0, as well as the collected fines here to support the audit. Okay, so CMS can focus on two things. One is to minimize the net budget B0. The other thing is to maximize the audit efficiency. So here we got some results because time limit. I will just quickly go through this. We found a trade-off between the net budget B0 and the audit efficiency. So basically, if you use a very harsh audit policy, it will reduce the net budget B0. But at the same time, it will lead to a low audit efficiency. So for CMS, it's better to carefully balance these two in order to achieve a good result. Thank you.
Hello, everyone. My name is Li Jia. I'm from East China University of Science and Technology. I have a co-author, Bing Gu, from Arizona State University. Today, my topic is about market concentration of online physician consultation. This is a story about what will happen if the healthcare is delivered online, and we focus on market concentration. Okay. The first idea is that market concentration may be good for the business retailers, but it's not good for the healthcare industry. The major concern is that for the healthcare industry, these supply is limited for each doctor or hospital. So if everybody wants to see a good hospital at a very high level hospital, then it will be very crowded. So the ideal status is that the supply and the demand is balanced. So some efforts have been made to reduce market concentration. For example, the family physicians in the US or the hierarchical diagnosis and treatment systems in China. The idea is that you should see the low-level hospital first, and then you see a higher-level hospital. Another interesting is e-consultation. That is, there is a trend that more and more health service is delivered on time. It is delivered online. That means patient can interactively consult a physician and receive the related medical care or advice when needed. There are some advantages and disadvantages for this new service. The major advantages is may reduce costs, save time, provide some value options, or equal access to the national-wide medical resources. What we are interested in this research is where the e-consultation market will be a long tail or a superstar market. That is, when the service is delivered online, the patient has a choice to choose a doctor as a nationwide. What will happen? It will be more concentrated or less concentrated. The second one is what information technology can do. Here we say information disclosure mechanism do to reduce the market concentration. So here's a research hypothesis. The first one, we have two competitive hypotheses. The market can be more concentrated or less concentrated. So each one we have some reasonable The other research question we're interested in, if information disclosure mechanism can be used to reduce such kind of market concentration. In this research, we focus on two types of online signals that a physician can send online. The first one is reputation. Okay, every review site has this information. The second one is self-representation. This is a new one. That is, a physician can present himself or do some activities online. For example, he can post he can post articles or provide free consultation services. So we are interested in the effect of the two signals. We hypothesize that if the market is sold many doctors with strong online reputations or strong self-representations, the market will be less concentrated. The logic is that if you have some high reputation or high self-representative doctors, then the choice set for you is enlarged. That means the supply of the market is higher than before. You can choose some not very high position doctors, but with good reputation. Okay, we test our ideas from the howdive.com. This is a e-consultation website, a leading website in China. They provide both paid services and free services. They have search engine recommendation systems, social networks, and here is the physician homepage. We can see we have gift, we have ratings, we have articles, we have service history list, and so on. Network crawler was developed to collect data. We have 8 years data, and we choose 3 diseases for analysis. The analysis unit is the physician year, so this is our panel data. This is a measurement. We have some control variables. Here is the empirical model, and we feed sales rank, reputation, self-representation data into the following relationship. The focus we are interested in is first beta 1. This measures how quickly Dr. J's demands fall as the sales rank increase. And the beta 4 and beta 5, this measures the moderating effect of self-representation and online reputation on market concentration. Okay, this is the result. For most cases, it's significant. So we just read the result. The first one is a long tail superstar effect. Okay, the result is that it's absolutely a superstar effect. So the thing is worse than the offline. So if the service is delivered online, it will be more concentrated. This is a 80-20-80 rule. That means 80% of the orders are dominated by nearly 20% of physicians. So this is a superstar market. The second one is if reputation can be used to reduce market concentration. The result is if the reputation is measured by either review volume or gift number, the result is significant. However, if the reputation is measured by review score, we don't observe any effect. A possible explanation, we observe a ceiling effect in the review scores. That is, most doctors have a top score. That means it's very difficult to distinguish doctors from the review scores. There are 2 possible reasons for this phenomenon. The first one is the patient may think that I will see the doctor in the future somehow, so I don't want to have a bad relationship with the doctor, so I just give a good score or just keep silent. The second possible reason is that the platform may have some manipulation on the very bad reviews. So we see some positive bias in the data. Okay, here is the result for self-representation. We also see that self-representation help to reduce our market concentration. That means if we have a market. Okay. Sold by many strong self-representation, our physicians, the market will be less concentrated. Okay, question?
Thank you very much. So So just to let you know that we secretly launched a mileage program at White. That is, if you fly over 1,000 miles, you get 1 more minute in your presentation. So John has flown at 8,000 miles, so he got 8 more minutes. He didn't use up that. Anyway, next year I'm going to fly back to China and then come over here. So
16 minutes.
Okay, cool. So I do have lots of questions, but I think, given limited time, I would like to open the floor to the audience if you have any questions. Ravi.
So this is what I asked is this going to be a superstar market or a long tail market? So one of the studies we have going at Hopkins with my co-author Phil Fan is on telemedicine. It turns out our findings so far are somewhat different from yours. I'll tell you why. It depends on the marginal cost of delivery. If a neurophysician takes about 32 minutes to see a patient face to face, she takes about 27.5 minutes to see that patient online. There is a capacity constraint on most specialists. So it's not like a Philharmonic which records one CD and you can sell thousands of that CD so that the New York Philharmonic will get 90% of the sales, all the other orchestras don't get any sales. Here, because of the capacity constraints, we find there are other effects associated with telemedicine, with online delivery of care, but for specialists, market concentration, if you look at the inverse Herfindahl index and similar reciprocal correlational measures, there's not much change because capacity constraints drives outcomes in specialist markets.
Okay. Okay. Thank you for your good point. I would like to explain the order used in this research is actually the paid service via phone. That means the capability is not limited. The physician must provide service via phone.
Does the physician actually answer the phone?
Yeah.
So isn't there a capacity constraint on the physician's time, whether it's face-to-face or phone?
Yeah. I think the time is almost the same.
So how does the superstar market happen? Because isn't it capacity constraint? Isn't the physician's time?
Okay, there is an upper limit for the supply. That means the doctor will be very busy, but there is an upper limit.
Go ahead, Brad.
Oh, okay. My question's for Heiko, which is, I think, really cool paper. My question is, why did you expect a negative diagnosis to elicit such a strong response? And that, my thought process would be that a violation of expectation in terms of diagnosis is going to elicit the more. So if they walk in and they say, Greenwood, you drink too much at conferences, you have cirrhosis of the liver, I'd be like, well, that's probably expected. But if they go and say you have strep throat, I'd be like, oh, this is horrible, because it's not what I expected to happen. Whereas, so just the rote negativity doesn't seem to be as salient conceptually as the violation of the expectation.
Thank you. Hello? 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 How many minutes do I have?
You have 10
Well,
more minutes.
10 more minutes, okay. So, now, well, our thought process was the following. Negative and perceived negativity. So you may go in there and well, I'm drinking too much and it may be my liver, but hey, total loss of liver and kidneys and everything gone. That's way worse than I expected. So this was our line of thinking there. And we saw that from the data. So we had a 5-point Likert scale of negativity. So from as bad as expected to, oh my God, totally, undisputably, unimaginably bad. And in the latter ones, the very, very much worse than expected ones, we only had 2% of the cases. So as I said, very, very thin database there. But the general line of thinking was, if I'm surprised by the level of negativity, I could blame that on the physician. Not rationally, of course, just emotionally.
Well, my thought is that if we are surprised positively as well, so like the smoker that goes in and doesn't have lung cancer, you see like this look of such excitement, and that conceptually
Smoke more.
elicit the same response. So that's why I think it might be good to go towards violation of expectation instead of just sheer negativity.
Yeah,
Yeah.
thank you for that.
Yeah, Heiko, just one quick comment on the labeling, right? When you say negative, right?
Yeah.
Normally negative is a good thing in diagnosis, right? That's a negative, right?
Fair point.
I found that working with the Germans, makes a real cultural difference, right? In your rating, right?
Yeah.
It's from 1 to 6, online ratings for doctors, 1 to 6. And 1 is the best, actually. I was surprised when I go to the German web ratings, and so everyone is getting 1, and they're so happy.
That comes from our school grading system. And if you speak to laymen, do you have cancer? Negative. Oh my God, you're gonna die. No. So laymen typically interpret it the other way around. So massively negative, massive cancer, anywhere.
Olivia.
Comment on diabetic work. What percentage is type 2 diabetic patient in your thread? You say you have late tag type 1, type 2.
So they were about 70% of the patients who were
17 or 70?
70.
Okay. So it is skewed. I
Yeah,
feel that the discussions, the topics, and the ratings and so on can be different in this too, even though you have a dummy for that. But your models will blend the effects of other variables for both types. So I would suggest, unless you do interactions, and let's allow interaction, you may want to segment the data sets. Have you done so? For
So
type 1 and type 2.
So how we treated this type 1 and type 2 was we looked at what proportion of users in a particular thread have type 1 versus type 2. Because if you look at these discussions, it's mostly the decision of the person who's asking the question is going to be influenced collectively by all the responses in a particular thread. So that is how we conceptualized it. Like, what is the aggregate impact of all the responses for a particular
So it's not
question.
self-reported, type 1 and type 2, that I am a
No,
type 1.
it's individually self-reported.
Yeah, it is self-reported. So
Yeah.
my suggestion is that you can build 2 different models.
2 different models.
Yeah, and compare if you haven't seen, because significance can easily differ sometimes.
Yeah, I think that's pretty useful. Thanks.
So yeah, I actually have a follow-up question on that, Srikant. So if I get it right, so you find that those who post more frequently have lower quality, is that right? That is the volume of
Yeah,
posting.
that's right. That's right. Yeah.
Okay, so I guess you look at the quality right from a clinical perspective.
Mhm.
So there are guys right who might provide social support to others, like
Correct.
saying right. So go strong, something like that, which has
Right.
nothing to do with the clinical quality, but it's more like encouragement. So just wonder whether you take a look at those.
Yeah, I think that's a great question. So when we actually designed the study, we did consider that patients might be purely providing emotional support.
Yeah.
So that is a reason why we actually had the physicians also classify all these threads based on what kind of questions they're asking and what kind of responses. And we only focus on the posts which deals with the informational support and not more on emotional support.
Specifically, we look at diagnosis, medication, treatment, because these impact patient safety if somebody else follows the advice.
Right.
And somebody else following the advice may be the person who has asked a question or some other casual reader who's browsing the net. So, and the clinical evaluation can be done only when there is a clinical question.
Yeah.
So the quality measure is a clinical quality. And we find that many of the perceptual measures of goodness for social networks does not work here. And that's, that we thought was.
Just to follow on from the distinguishing between the 2 types of diabetes, I think it would be really interesting to look at rare diseases and forums around rare disease where the patient becomes the expert and in many cases knows far more than the clinician does. And rare disease groups become very dependent on patient fora.
Actually, there are great difficulties in doing this because the physician time in evaluating each of these posts is a tremendous cost, and we have to move these systems out of social network systems to create a separate, which he has not talked about. We had to create different systems where physicians could sit and evaluate these threads and questions rapidly. So an alternative system for physician evaluation was created. And he has a similar thing with Parkinson's disease with neurologists looking at something else, and the costs are too tremendous. So we just stuck to what our affordability was on these two diseases, and we stopped there.
Yeah.
Funds were over.
No, I mean, pragmatically, I understand completely. We've just
Yeah,
done
and-
quite a bit
and-
of qualitative research around patient support platforms and found that in rare diseases, the patient very much becomes the expert. And we've actually heard anecdotally, for example, that people with Angelman syndrome, which is very rare, are admitted to the ED or the ER for us, and they go on to, the patient's family go onto Facebook to show the doctors what they need to be doing.
Yeah,
So-
this is not only true for rare, but also neglected diseases. There are 20 diseases that are considered as neglected because the quantity of drugs that's needed and the number of patients becomes too low for commercial viability, and these are government supported. So that is another case. But as I said, there were some other limitations, which is nothing to do with academics, but more financial. But we stopped where we did.
So actually, my question to Xu is that, so can you shed light on what is the current practice of CMS punishing those, cheating behavior? Like in the auditing, if they find that some nursing homes are cheating, is there a serious punishment or something like that?
Well, the sad truth is currently CMS doesn't do any audit. So those nursing homes, those inflators, they just seldom got catched.
Okay.
So well, that's why we think incorporating audit system is useful in improving the information accuracy of the reading system.
Okay, sounds good. So any further questions from the audience? I guess we are ready for one last question.
Yeah, actually, I also have a question for Han. So I think it's very interesting. Oh, sorry.
Thank you.
I think it's very interesting, and especially interesting to see you find the trade-off between the efficiency and the budget constraint.
Mm-hmm.
So I'm wondering, have you further explored from this direction? Because I think it could be a very good data-driven optimization model regarding to balance both efficiency and budget constraint in one objective function, and deliver some message under what type of condition you put more weight on certain certain regime, something like that.
Yeah, I think this is a very good point. And this currently we haven't done so much on data-driven things. We formulate this problem analytically, and we run the simulation to get a result. But I think that can be something very promising to do next.
Thank you very
Thank
much.
you.
So let's give one round of applause to our great panelists. Thank you.